chronic myeloid leukemia. That quest reached its dead end at last on April 1st. India's Supreme Court rejected the Swiss drug maker's patent application. The case was watched closely by virtually everyone with an interest in selling medicines or benefiting from them, including the drug firms, trade officials and patient advocates. Drug companies facing paltry growth in rich countries want to sell medicines to developing ones where demand for the new drugs is rising along with the rates of chronic disease. But governments are keen to boost their own pharmaceutical firms and are wary of patented drugs' high costs. In this edition of Public Forum, we discuss the drug patents role. Joining me in the program is Dr. Meera Shiva. She is coordinator with Initiative for Health and Equity in Society. She is also associated with Rational Drug Movement and People's Health Movement. Quite a pleasure having you here, Dr. Shiva. And we are also joined by Mr. T.C. James. He's a director with National Intellectual Property Organization, created with the Research Information System for Developing Countries. Welcome to the program, Mr. James. Let's start the discussion with you, Dr. Shiva. The rejection of the Novartis petition challenging one of the most progressive tenets of the Indian Patents Act of 1970, as was amended in 2005 by the Supreme Court. This certainly throws a lot of hope for the pharmaceutical companies, for the patients, and for the drug manufacturers locally, as well as it gives a lot of a stern example to all those drug manufacturers outside who would like to come and invest in developing countries. What is your
Patent Act and how, affordable medicines were made available because of the Indian Patent Act of 1970 and why the 1970 Patent Act came in the first place. So if you read the verdict, that what the judgment that has been taken regarding this Novartis product has been keeping in mind the history, the present socio-economic and public health reality not only of India but outside, keeping the TRIPS liabilities in mind. So Section 3D, which was, this is the one that Novartis was apparently having problems with, which anyone dealing with public health and dealing with the issue of access to medicine feels very strongly about. They're extremely happy, and I don't think it's feeling happy or unhappy, relieved. Extremely relieved, because it would have implications for access to affordable medicines for a lot of different health problems in the coming time, and under no circumstances anyone who wants to bring in a drug, even if it is say incremental innovation with significant efficacy, that this judgment stops that. It doesn't, So to say patent, they are not giving patent, no. Incremental innovation is promoted, provided there is significant efficacy. For frivolous or non-significant thing, no, patents not. So will not be given. And I think that's a very important message.
Exactly. Drug patents, Mr. James, is designed to create profits that enable more research in the area and ensure that people find new medicines for their diseases. But they are being, to an extent, misused, I would say, as is generally viewed by the big pharma companies to make in more profits.
People forget it is also in accordance with the TRIPS agreement, because the TRIPS also in Articles 7 and 8 clearly state that this is given for the betterment of humanity, for easier transfer of technology and all that. As regards the question whether patents are for profit, the basic principle of patent law is that is to encourage innovation and innovation. So it is not talking about investment protection. Investment protection is a side effect of patent monopoly, because it is giving a particular kind of monopoly, but it cannot go totally in that way. It is there to encourage innovation, and that is where this judgment has come very well, while it said that this particular claim in the patent application is not patentable as per the standards laid down in the Patents Act, which is in accordance with the international norms also. But it nowhere, it's very clearly, I remember, I think it's, the judgment very clearly says in para 190 said that it is not to say that section 3D bars patent protection for all incremental inventions of chemical and pharmaceutical sectors. So the lordships have sent out a very clear message. We are for patenting, but those patenting should be for genuine innovations, which really is a step forward, not a side step.
But you know, sir, take us a little more deeper into the section 3D, because this section 3D, if I'm not wrong, was also very hastily drafted, as was reported. Sir, looking into the depths of this section 3D, there are certain things which in fact have prevented Indians to go in for any faulty agreement with any other pharmaceutical company from outside as compared to any other country because of the section 3D. So much of it can be credited to section 3D.
Let me first of all clarify one.
Supreme Court's judgment on the case of Novartis has set a precedent against the practice of evergreening. Evergreening is a practice where manufacturers introduce modifications of the drugs to extend a 5-year patent on them, and India, along with Brazil, Thailand and South Africa, have been against the practice of evergreening. But before going into the break, we were talking about the safeguards which are enshrined in the patent law, and where our panelists also talked about compulsory licensing for some blockbuster drugs, which can be done if at all the original manufacturer fails to sell it at affordable rates. Dr. Shiva, how foolproof the compulsory licensing process is like?
No, I'm saying India hasn't used it for long.
Right.
It has been there because TRIPS came into force in 1995, the rest of the world, but because we had the process patent, for us to amend it to make it to product patent, we were given 10 years transition period. And I want to just go back a little bit. South Africa had so much of HIV, you know, almost 25% HIV positive, it was coming in the antenatal care, etc. And for them, they needed antiretroviral drugs. And the patent holder, from those who are dealing with HIV, those who are, you know, from social, who had social concerns, public interest, human rights concern, Doha Declaration on TRIPS and Public Health, that's why it says that, you know, just the profits, etc., and intellectual property right, if it's going to be at the cost of public health, is not on. And countries have a right to make their patent laws, you know, keeping their concerns, you know, their public health needs, etc. in mind. And that was not all. There's an international commission on IPR, you know, innovation and public health, because over the years you could see that intellectual property right, strongly protect, was becoming a very major hurdle to public health and access to medicine. So if this international commission was formed, it was because it was becoming pathological. And I'm saying this in the context because any country, when Thailand tried to use compulsory licensing, they had a backlash. And it's important to remember. And the WHO person who was there, you know, who had sort of, you know, said very clearly that it is in keeping with even what WHO says about, like, you know, TRIPS and public health. Again, coming to the Novartis case, you know, it's, you know, 120,000 rupees per month.
That's right.
And 8 to 10,000 rupees per month, which also is very high for large number of people.
Right.
In a country where 80% healthcare is out of pocket. So the scenario is such, and we have the burden of communicable and non-communicable diseases, hypertension, diabetes, cancer, all increasing. You know, causes of increase are also known, but they also need to be addressed. So it is the state's responsibility at one level to ensure that the flexibilities get used and the public health is protected within keeping what TRIPS agreement that one has signed. And so when this Supreme Court judgment comes, so many people are saying that, you know, it is because that's what Novartis was saying. It was violative of TRIPS. It was not violative of TRIPS. And it is basically giving importance to the Constitution of India. And we have to go by the Constitution of India. We don't have to go by the Constitution of the companies or whatever they have, or their, you know, the interests. They
might be,
you know, spokespersons in their own senates and in all their governments might have and put pressure through free trade agreements and bilateral. You know.
But what would you like to say about these, ma'am, because Novartis has claimed that we have given medicines free of cost, we have donated them to 95% of the people. There are reports, again, I'm quoting the media reports only, where there's written, in fact, one of the gentlemen's, some Paul was also quoted from Novartis, where he was quoted that he's given that this was given to about 95% of the people, but the media report claims that those 95% of people were
Over and above, you know.
okay.
And use all this as a you know, for monopoly control.
Okay.
And also patent linkages. I will talk about it.
Okay, we'll take a very short break, ma'am, and after the break we'll discuss the other aspects of this issue. Please stay tuned. Welcome back to Public Forum. In Public Forum today we are discussing about the drug patents role. We are also joined by Mr. Anand Grover. He's a senior advocate and the director with Lawyers Collective. Welcome to the program, Mr. Grover. Let's start with your initial remarks, first of all, on the Novartis judgment. It was seen as a landmark judgment for a lot of people.
Well, it is a landmark judgment because over a long period of time, after 3D was brought into force, and you have to understand the history of 3D, it was consistent. But Novartis was backed by the whole of the multinational lobby, and they first challenged it in the Madras High Court. Then they wanted, as well as about bioavailability, do not constitute efficacy. They have to do different tests for efficacy, as they say, in the animal to see whether it is more efficacious. Does it heal better? Suppose it is cancer. The cancer cell, if it is 1 kilogram in the body, you put the drug. Does it become 50 grams,
Right.
100 grams, 200 grams? And compared to something like, in this case, the original molecule was imatinib. What is the difference? They didn't show anything because these are incremental changes only relating to the way you handle the drug. It becomes more pure, it becomes more soluble. It doesn't change the therapeutic effect. There are other drugs that may change, you know, depending on what is known as the stereochemistry, how the molecules are arranged. But in this case, they were not able to show it. So this case is very important in terms of efficacy. The sort of myth that is perpetuated by multinationals, unfortunately, that we don't give patents to new drugs and really innovative drugs is totally untrue. This law was based on what has happened in Europe and North America and Japan, where 76% of the drugs which were allowed patents are new forms of known substances. And that is why this 3D was brought, to make sure that really new forms which have no therapeutic benefit should not be patented unless there is significant efficacy. So two things have been reaffirmed. One is that 3D is alive and kicking, as I said, it's intact, it has not been damaged, which was the attempt by Novartis and the multinationals, not only in the court, they have done that even through lobbying. The US CII conglomerate includes industrialists from India who are pro-multinationals. They want 3D to be thrown out of into the black water from the legislation. And the Novartis challenge also wanted it watered down. That has not happened. It is very good for the patients, it's very good for the generic industry, it's very good for patients, not only in India, but the whole of the developing world, where India actually perfectly in line with TRIPS. Mr. Sharma, our Commerce Minister, has given an interview, as you have noted, in Geneva, where he has made this point very clear. And fortunately, nobody has thought it fit that we should be taken to the dispute resolution mechanism. That is the option. If we are not in compliance with TRIPS, states can take us, and nobody has thought it fit. In fact, governments know that we are very, very compliant. Secondly, investment into innovation in India. By the way, nobody has said this, but from the time we actually entered into TRIPS compliant regime, there has been disinvestment by the pharmaceutical multinationals. If you go all over India, and this is very well recorded in all literature, they have been disinvesting. They are not producing drugs here anymore. Less and less. They are only importing. So here is the question of investment. You are disinvesting for the last 5 years. And they are not investing in innovation here, I'm sorry. They are investing in innovation in Switzerland or in the US, but the innovation is based not on the research. Most of the new molecules are publicly funded research based, which is a different issue which we can come to in a minute.
Which means that the investment is actually not happening here when it comes to innovation, research or development in the
By
country.
multinationals.
By multinationals. So here claiming that, you know, this Glivec decision would affect R&D to an extent in the country is actually a falsely placed statement. Is it, Mr. James?
It is. In fact, the companies, whatever little investment they are doing, that's only at the third stage of pre-clinical trials. Nothing more than that. Real innovation investment is not taking place in this country. So this is only a ploy which they are highlighting. Number one. Number two, just because one patent application was rejected, as against, as Anand Sharma mentioned, 147 patents granted. What does it make any sense? Does it make any sense? Now, what is got 147 patents post 2005, and one patent application was rejected, and they are raising, oh, heaven has fallen. That's not fair. Even again, as Mr. Grover said, investment is really going down in the pharmaceutical sector, not going up, and this was what was pointed out by Iyengar committee also. Up to 1957, this was what was happening. It was going down.
But you know, this case, as I said in the beginning, Mr. Grover, I would like to come back to you again. This case would have certainly opened avenues for other players too, because there are more battles to be fought here. It's just not Novartis, but there are other players, maybe not related to cancer, but to other diseases, to HIV, to breast cancer, to other areas. They're also there.
Well, you know, the thing is, you have to understand that the patent law itself is very unusual compared to other intellectual property law. The patent is never presumed to be valid. It can be challenged even on the 20th year, even after the 21st year. So there are so many provisions, and this is across the world, not only in India. But in India, we have been able to use all the flexibilities, which means, as other people have pointed out, when we entered into the TRIPS regime, what we got was flexibilities. What is the meaning? So patent can be granted because something is new, product or process, new, innovative, inventive, and it is industrially applicable. But what is the meaning of new? That is left for the country to decide. That is the flexibility. So we have got the flexibility in writing that under section 21J, 21JA and 3D, new forms of known substances will not be granted patent unless they are significantly more efficacious. So it's our right to use that flexibility. Now India has been innovative in lawmaking also, you know. So this has been followed in Argentina, it has been followed by Philippines and Zanzibar now. So it's not that people didn't know about this, but we were able to make not only people in parliament, but civil society. We have been active from 2001 in civil society movements, and we have been able to influence through various political parties, through government, etc., to bring about a law which is creative, which helps in the disagreements.
What would you like to say about the claims that Novartis made of distributing these drugs?
That is a lot of hogwash.
Donating these drugs, in fact.
It's pure hogwash, as English people would say, because this was in the court case, in the Intellectual Property Appellate Board, they raised this bogey, we challenged it, they never rebutted it. And now that it is convenient, they can bandy about what they are saying, which has been rejected by us. And we know what is happening. What they have done is actually, when they say 95% of 100 patients, how many times did they give it? We know that they gave it once. And they say there are 100 people, we have given the medicine once. That's 1%. To 100 people, they've given it once only, and that is 95% coverage according to them. But unfortunately, you have to give it every day for the rest of their lives. So most people fall off the table, and most of the people are now going to other generic companies. They are not dependent on this charity.
So it's a one-time philanthropy that they have done, maybe.
Not even one time. In fact, they have been, there have been complaints against the NGO which has run it. There have been criminal complaints in Latin America of the NGO which has been running this GPAP program, as it's called, which is funded by Novartis, because there are other reasons why they're doing it. It's not philanthropy. They are trying to build up a good image. The pharmaceutical companies do not have a good image, by the way. I mean, historically, they have not had a good image. By the way, if you want to know, In Germany, they were responsible for deaths on experimentation on human beings. Pharmaceutical companies generally. That has been recorded. That's why we had the complete change in law in clinical trials and consent procedures. That is one. But after that, say recently, South Africa, 37 of them filed a case against the South African government. They got a slap on their face. After that, they wanted to change their image. And this was the new way. But they really want to fight for profits. And they don't make small profits. They make million% profits. Like take an example, in South Africa, $1 a year. That's a blockbuster drug. It cost me $800 million. This was their own study. It's known as the tough study. After that, there have been 4 studies. The Public Citizen in the US, the Congressional Budget Office, and now a recent research study has come. And they have put it from 200 million to 100 million and $50 million. The claim of $800 million at those days now, which is 2 billion equivalent in price, is actually 50 million. So in Novartis itself, the first year, they spent not more than $400 million for clinical trials. Their first year turnover was more than 1 billion. And today, their turnover only on this drug is over 18 billion.
Okay, okay. So those are very startling figures. We'll take a very short break on that note, and after the break, we'll discuss more aspects of this issue. Welcome back to Public Forum. In Public Forum today, we are discussing the drug patents rule. Problem is something which we hardly discuss in the public circles when it comes to affordability of medicines or accessibility to medicines in the country, because we know it's the case of Glyvec, a medicine which was available to us, which is in fact available to us, but we know the price gap too. Dr. Shiva, how do you look at this particular issue of pricing?
I think the issue of pricing is the most important, because once you have the monopoly control and you fix the prices, and that's for 20 years, and in countries where they allow patenting for another 20 years, another 20 years, and others, countries which are least developed have to basically, bank on these manufacturers for getting their drugs. That's why countries like India, which make generic equivalent at much lower cost, becomes crucial. So the presence of generic drugs which are affordable and of quality drugs becomes extremely crucial. And in Doha Declaration on TRIPS and public health, this issue of overpricing is being seen as a very important issue. And also, as I was mentioning at the WHO Commission on IPR Innovation and Public Health, that this is the biggest deterrent. And if you have the drugs and people cannot even afford to buy it, neither the governments, because big chunk of the budgets will go to, like if any antiretroviral program. So that is one issue, but trying to put under an umbrella and say 30% of our drugs from India are counterfeit, which is absolute rubbish, As from public health concern, we would like to have quality drugs, but if they say 99.99% or 100%, that is quality, and use that IPCA thing as label, calling it counterfeit, and then they say all generic drugs are bad, and you go and do a big propaganda. And now many things they're trying to bring in the free trade agreement as a threat, So you talked about the issue of pricing. So anything in transit, etc., like 14 ships that were held up in Amsterdam, calling them counterfeit drugs. So we have to be concerned about also the future threat, because many different hurdles will come, whether it's going to be through the free trade agreement and ACTA, the anti-counterfeit trade agreement, where all the generic drugs, the threat, and putting this thing about calling them counterfeit is something that we will have to be needing to deal with, which does not under any circumstances mean adulterated, contaminated, and anything that's purposely done, that those people should not be punished. We are not saying that.
Right, but we have the world's biggest generic market here, generic industry, and we also of course have a patent law, and we have a great demand too, but we have the inability to pay, and that's one of the realities which we have to really face here. What are the problems here, and what do you think can be done in order to bring in more drug companies and in fact ensure that they do some innovation here? Because it seems that they are not even given enough safeguards in the law.
No. You see, you have to understand that innovation is one issue. Availability of crucial medicines for the public is another issue. 70% of the people are not getting medicines, okay, because they have to buy privately. So we have now systems which are working. For example, the Rajasthan government has made it clear that they will buy generic drugs,
right,
and they will make them available free of charge, which requires the generic industry is robust and able to produce the essential medicines, and 3D will help. Now, therefore, the government has to take over providing free medicines. But if they are cheap, the government can do it. If they are not cheap, like multinational patented drugs, they can't do it. So this way, if we move towards what Rajasthan has already achieved for 1 year, they have already started buying generic drugs and making them available free of charge through their government.
We have the Jan Aushadhi outlets that have been opened in certain
No,
parts
but
of the
Rajasthan
country.
has started this
It has
in a
done it,
very
right,
big way.
right.
And that is the way to go. You know, that is one of the models. So it is possible that we can depend on the generic industries. There's a threefold element. One is the generic industry must be strong. They should be able to make reasonable profits for them to innovate. If they are also overpriced, they need to be regulated by pricing,
Right.
price regulation, which we
Right.
have. And then the government must buy affordable prices drugs to be making them available free of charge to the consumers who are the people suffering from ailments. All this is possible and achievable during this decade, according to me. We have to push this agenda from the government, from people like Mr. James, who has worked, who is now still working on this issue, like Meera, who's a health activist, a large number of other health activists, who will push this agenda, tell the government this is an agenda which is as important as any other.
Okay.
Health should be available at an affordable cost. Health, goods, services and facilities should be available free of charge at the primary health infrastructure level.
Right.
Sorry, I just want, we are talking about essential drugs.
Right.
All drugs in the market are not great. All R&D.
The life-saving drugs, that's something, ma'am, essential drugs, since you mentioned about it, the government has notified this national pharmaceutical pricing policy. I want to understand, because they have this national list of essential medicines of 2011. Does it include all the essential medicines, or what is exactly the way of...
See, we say that there are essential priority drugs, there are rational drugs, there are irrational drugs, and there are potentially hazardous which should not be in the market, which are banned and bannable, which should be banned. Huh? Now the thing is that is for now. This is the national list of essential medicine. The stand that the public health people have taken is that it should be cost-based pricing plus give them certain amount of profit, it is fine. You cannot have a market-based pricing, because if it is market-based, which is the brand leader? It is the newer drug where the most, promotion and marketing aggressively is done. By the way, the expenditure on that is much more than R&D, and which ultimately is
Only them. How do you regulate it? Cost-based, market-based, that's one issue. The other is the drug price control order, which already exists. That order is not based only on essential medicine. It's based on dominance, how much percentage of share you have in the market. Now there is
Commodities Act, DPCO, which they want to get rid of.
Okay, on that note, ma'am, we'll have to say goodbye to you. Thanks very much for talking to us. Quite a pleasure having you all here. So that's all we have for you in this edition of Public Forum. Thanks very much for watching. Goodbye.